Good afternoon, everybody. I'm so happy you're here today. I'm Sharon Spurlock, the Senior Director of Family Support at the St. Louis ARC, and today we have a fascinating topic, sleep. I think we've all heard so many things about how sleep really impacts our quality of life, and some of us have been challenged by sleep over the last year or so. So we're going to talk to a family member who took some sleep attitudes into his own hands and a sleep researcher to help us understand more about sleep, what the impact of a good quality of sleep is on our bodies, and what we can do to really create better sleep habits. Without further ado, I'm going to let our guests introduce themselves. I'm going to start first with George Bailey, who reached out to the St. Louis ARC to tell us a little bit about the work he's doing around sleep. George, why don't you tell us a little bit about yourself?
Thank you so much, Sharon. My name is George Bailey. My wife and I moved to St. Louis about 11 years ago so I could attend law school. And one of the really wonderful blessings of living in St. Louis is that it has a very robust autism community. This was important to us because our 3-year-old son at the time, now 14, was going to be diagnosed with autism here in St. Louis. We knew during our time living in Germany that he was autistic, but it was helpful to be able to come to a place where there was a really wonderful support system. Since that time, I was recruited by a number of my friends to participate in taking capsule beds and searching for solutions to creating kind of a more conducive sleep environment for kids with autism and other disabilities where sleep is a real issue. And so we've been working on that. It's been very fun, and we love being here. So love being a part of this community.
Great. Well, you definitely have the nicest background of anybody that's been on my show. So I'm very jealous of that fun pod. We may have to have you show us around. Dr. McCrae, thank you so much for being with us. You're joining us from the Mizzou Sleep Labs. Can you tell us a little bit about the work you're doing? I know it's connected with the Thompson Center.
Yes, so hi, I'm Christina McCrae. I'm a clinical psychologist and professor in the Department of Psychiatry at the University of Missouri, and I'm working closely with the Thompson Center for Autism and Neurodevelopmental Disorders here on a project that has been funded by the Department of Defense, and our goal is to help kids with autism sleep better. It's a family-oriented intervention that we're doing to work with the parent and school-age kids to help them sleep better, because we know that insomnia is a big problem in these kids.
All right, so I want to ask a little bit more about that, but before I do that, can you just tell us in layman's terms a little bit about what sleep does for our bodies and our brains and what's so important about a good night's sleep?
So in layman's terms, sleep is the third leg of sort of just basic health behavior along with diet and exercise. So what occurs during the night is basically physical and mental restoration. And truthfully, what makes doing research in this area so exciting is that in comparison to what we know about the other 2/3 of our lives, when we're awake, we spend a third of our lives asleep. We know comparatively little about what takes place during the sleep, other than we do know that it impacts virtually every aspect of our lives. And getting good sleep is good for health and daytime functioning, thinking, memory, those types of things. And not sleeping well is not good for health and how you think and feel during the day in general.
As you've done research, are you actually determining if the impacts of sleep are the same for people with autism and intellectual disabilities, or is that sort of a separate conversation?
So one of the underlying ideas behind the work that we're doing is that when we go in and target and try to improve sleep, we're also helping with arousal. And we know that there's dysregulation of arousal in the context of autism. So we're starting off with improving sleep and sort of looking at some aspects of arousal and cognitive functioning with this initial study. And we hope to sort of take the work even further and starting to look a little bit more at what's happening in the brain as you start to sleep better, and how you think and process and how you deal with arousing situations. So I see this as sort of the work that I'm doing with sleep is sort of a broader, like a starting point into sort of broader additional questions with sleep. And then the work with George is looking at another way. I mean, I do cognitive behavioral treatments for insomnia, but working with him and looking to go sort of down the line of the zPods is looking at another way of helping to improve sleep in kids with autism.
Yeah, I think not every person has their problems met with the same answers. So it's good to have multiple options. George, why don't you tell us a little bit about your motivation to really start looking at these sleep pods and what the zPod is designed to do?
Yeah, thank you very much, Sharon. I mean, we're very careful about, what we claim, as we put this forward as a solution. And I think it's a solution of many solutions because sleep is multidimensional. I think that there's as Dr. McCrae was mentioning, there is a heavy psychological component of sleep. And it's very striking. And so, but what really struck me about this particular approach of having an enclosure is that there is kind of like a hug feeling, that feels, that kind of feels that sense of security, that need to be surrounded and safe. That's a real deal for a lot of young sleepers in particular, where they really feel like, look, I just need to feel safe. And a lot of the kids that we deal with, we get a lot of reports of, my kid is sleeping in a closet, my kid is sleeping under the bed, my kid is sleeping in a bathtub. I even heard one, my kid will sleep in the dryer. I would not recommend that, but it's very intriguing to me. And so when we first came across these capsules, the idea of a capsule bed was not born out of a desire to assist the autism in other populations. That had nothing to do with it. It was more of a novelty in Asia to create micro hotels and airport places where you could stay at the airport, in the airport, and not have to check out an entire room. And one of my friends stayed in one of these, thought it was kind of cool. We brought it back to the United States to sell a few to a friend who's created a Star Wars themed living space, and they needed a bed that was really convincing. And if you're looking behind me, this is just a digital picture right here. As you can see, my hands are kind of going in and out, but it certainly has a more persuasive style in terms of looking futuristic. And so we started like that. And then we started thinking like, well, what else would this be good for? When autism came up, I was a little bit skeptical because I think that, we have to take any solution that's oriented towards the autism community scientifically seriously. You can't just throw stuff out there and say, hey, I think this would be a great idea. So we talked with a lot of doctors, a lot of psychiatrists, and as well as occupational therapists, and then autism families to see like, hey, would this actually be helpful? And so, again, just to give you a basic description of what we're talking about, behind me, you can see a control panel, and that allows the occupant to control the lighting and to a certain extent the sound and fan control. And so we tested this out with one family, a young woman, 13 years old. She has autism, schizophrenia, bipolar disorder, and OCD. And she was sleeping 4 hours a night in her closet, and her sleep jumped immediately. And when I say immediately, I mean, it was a literal overnight change from 4 hours to over 10 hours a night, which is standard for her age. I wouldn't prescribe that necessarily for somebody my age. We should be sleeping 7 to 9 as adults, or so the numbers say. But that jump was so shocking for us that we thought, okay, maybe we should look into this more seriously. And we've had some pretty amazing situations since. I just got finished communicating with a mother that we set up with the bed 1.5 weeks ago, and her son, who wakes up every night in the middle of the night, has stopped doing that except for once while he's had the bed. And again, I don't know why. I can't quantify an explanation, so I'm very cautious about that. And this is what I love about working with Dr. McCrae, is that she wants to help us reduce it down to something that can be scientifically articulated. And I think that it's important in doing so that we never overstep. I'm kind of, in this full disclosure, I'm the worst of all worlds. I'm a lawyer and I'm a salesperson. So you really can't trust anything I say. And so we go out and we find someone like Dr. McCrae and say, we want you to really look at this and to see like what's going on. And it's not going to be for every kid. we're really careful to make sure that people know that what works for, one child is not going to work for another. But there is a strong sense of safety that we think that these children are deriving. A lot of them are high anxiety. And we want to look into that. We want to understand it.
Thank you very much. And you've really saved me a lot of trouble by saying that this is not something we're endorsing right now.
Yeah.
I think it's important at the ARC that we're sharing possibilities with you as families and people with disabilities. And so there are lots of possibilities to make your lives better. And if you're thinking about improving your quality of sleep, this is something that is cutting edge. It's just now being researched to determine whether or not it's going to have efficacy. And that's really nice that we're going to know that. I'm going to shift back over to Dr. McCrae to talk about some of the other strategies that you're using, because you mentioned a family intervention and you also mentioned cognitive behavior therapy. And I want to make sure we're sharing kind of all these different concepts that to help people with their sleeping. And these are really specifically for folks that are struggling with their sleep.
So what I do in my work, I work with individuals who have what we call chronic insomnia. I mean, insomnia is very pervasive in our society, it's like an umbrella term, have a poor night of sleep, and you could call it insomnia. But when we talk about chronic insomnia, it's somebody who has difficulty falling asleep and staying asleep, 3 or more nights a week for 3, 6 years, even in some cases. So that's the type of patient or individual that I tend to work with in my research. And we do tend to see a lot of chronic insomnia in kids with autism. And a common approach with these kids, as well as anyone with chronic insomnia, are cognitive behavioral techniques. And the umbrella term you might hear is cognitive behavioral treatment for insomnia. And I call it an umbrella term because within that broader cognitive behavioral treatment for insomnia, you might see what's called sleep hygiene. You might see a technique called stimulus control. You might see a technique called sleep restriction. You might see relaxation techniques. You might see cognitive therapy. And there might be slight variations on that depending upon who you're working with. And if you're seeing in the clinic, you might also see more or less of one of those components depending upon who your therapist is and what they might sort of do to try to target specifically what's happening with your sleep. And what we're doing with the families of school-age kids with both autism and chronic insomnia is we are attempting to work with both the parent, at least one parent and the kid on these cognitive behavioral techniques. But we really scale it to if the child is able to be very, very interactive, then they can be really involved. If they're not able to be as interactive or not as interested, then we work more with the parent. And we did some pilot work with those techniques before we moved on to now we're doing a randomized clinical trial. So I think that those are some of the most common techniques. And there's an autism, I'm kind of blank on the name. There's a pathway for targeting insomnia in autism, and includes a lot of sort of parent behavioral training, the behavioral techniques to parents. And then that can be used with even very, very, very young children. But as you move into school age and kids become a little more aware and start to have, greater ability to think in certain ways, and they're going to school and interacting with other kids, that's the time where we felt it was important to start intervening with techniques where they could be a little more involved. And it's not just the parent doing something to sort of set the stage for sleep.
I think it's really important for kids to be engaged in choices and decision-making around that. You used a few phrases that some of them I'm familiar with and some I'm not. What are some of the more common like sleep hygiene things that you might suggest to a family? I'm familiar with that.
Yeah, so sleep hygiene, when it's in the context of CBTI, good, but we know now, like the American Academy of Sleep Medicine has put out a paper that's sort of talking about that as a standalone. It was like the standalone. If you weren't seeing a sleep specialist, you're probably going to get some form of sleep hygiene. And the evidence just isn't really there to support it as a standalone, but it does include all those sort of things that you want to sort of check the basics first. Are you having too much caffeine? Hopefully kids aren't doing this, but are you smoking, using different stimulants, that type of thing? Are you exercising or being too active, too close to bedtime? So some of those just basic behaviors, and subsumed within that now these days is the screen time, which is a big thing, right?
What does the research show about technology and sleep? Are we really supposed to shut everything down an hour beforehand?
So I think we're still seeing research in this area. I will say that what I do in my work is the recommendation that we give, that you parents encourage getting off the devices at least an hour before bedtime. In some cases, we'll recommend have a spot in the house where everybody puts their electronics when you get ready to start your bedtime routine. And there's two reasons why I think that that's important to consider. There's the whole blue light and then the impact that that has on keeping your brain awake, essentially. I think the other component with the screens that maybe gets less attention is how arousing it is to be sort of flipping around and searching on things on your devices. So from my perspective, I think it's both of those things that can interfere with sleep, and why we include that in the interventions that we do is that we recommend.
I love hearing you say that, because I agree that it tends to be a combination. I've been reading about some of the studies that have come out lately that have showing that, well, blue light is a big deal, but there's also something about that activity. It's the thing that you're doing. So, the blue light, it makes a lot of sense because our brains are trained to identify when it's day and when it's night. And that's when we start to kind of release some of those chemicals. When we're getting signals that the light is going down, then we're releasing some of those chemicals that are sleep inducing. But then at the same time, it can't be good for us to be doing something that we just find really engaging right before we go to bed. And I'd like to kind of add that it seems to me like sleep is a learnable behavior. And I don't know if you agree with that, Dr. McCrae, but it seems to me like we have the capacity to be able to change the way that we look at sleep and the feelings that we have associated with it.
To some extent, I agree in terms of there are different learning principles behind what we do with cognitive behavioral treatments and other things that we do. But where I hesitate to say learnable is thinking about learnable in something that you actively do. Because we know for people who have trouble sleeping that trying to sleep is sort of a paradoxical thing, sort of like can inhibit it. So the way I think about it is what you are learning is setting the stage for all those pieces to put into place so that then sleep can occur naturally, right? So I think you are right, but I just want to make sure that sometimes when people hear that and then they interpret it and think that you can like sort of work with your kids and be like, you're going to learn how to do this better. And then that can be counterproductive. So it's more set the stage and then allow sleep, which is a natural process, to occur.
Agreed. No, and I see where you're going with that, where, the anxiety that we actually put into the sleep, if it becomes an obsession for us, there's even I guess you could name it for me. There is an anxiety that exists, clinically diagnosable, where you're so obsessed with getting the right amount of sleep that in and of itself actually decreases the efficacy of your sleep.
Correct. That's arousing. You're worried and anxious about it, and then that's counterproductive to winding down and getting ready for bed.
Vicious cycle. I do like building up routines around bedtime, though. I think especially with kids with autism, routines are great. All right, I have so many questions. I'm going to do a bullet round of questions. The first thing I want to ask is, if I can't fall asleep, should I stay in bed or should I get up and do something else?
Oh, so when you were saying, I don't know some of those terms, the stimulus control is a type of technique that you use with individuals with insomnia, where we instruct them to get out of bed if they're not sleeping after a certain period of time, get out of bed and go in another room and do something non-stimulating, because getting at these learning principles, the idea is that if you're staying in your bed, you're awake, maybe tossing and turning, maybe starting some thought processes about, oh, I'm not sleeping, and maybe catastrophizing, that you are reinforcing a connection between your bedroom with being awake. And so that is a common technique that we know does work well for many individuals.
Are books a good alternative to screens before bed?
This can be tricky. So what I do when I work with patients or research participants or I do a lot of training of therapists in training. What I tell them is it's based on the individual. Are you the type of person that you're reading a book and you get so caught up, you can't put it down, and then you're reading all night because you so want to get to the next chapter and the next chapter? Well, then for you, reading a book isn't good, right? But if you're the type of person who can sort of be reading something, and then when you start to feel sleepy, feel fine putting that book aside, then I don't think it's a problem, right? So it's individualized, sort of what impact does reading have on you?
Well, this goes exactly to what you were saying about the cell phone. It's where, if you find it particularly engaging, that could be the thing that's keeping you awake. If what you're reading before you go to bed is Stephen King, then, good luck with,
Exactly.
that.
Yeah.
Yeah.
Whereas for me,
boring.
3 pages and I'm down and out. So that's a good
but if
technique
it's like,
for me.
Yeah, if it's Good Night Moon, I think you're covered. So.
Yeah. Or
like
short
that.
stories or something a little duller, then you might be okay.
Well, that's probably why they keep kids' books pretty short. So if you're going to read to them, you can get to some closure. What about caffeine? Is there a particular amount of time that you should go before bed where you're not drinking caffeine?
Okay, so this is what I do. So I'm going to say, and I'm being a hypocrite, you shouldn't be drinking caffeine, but I know that's not. Okay, so what we do for people who have chronic insomnia, we try to get them to stop all caffeine at noon. And then if somebody's really, really hardcore, we say, all right, after 3, don't have any more caffeine. But we know that it takes, hours for caffeine to clear out of your system, the half-life of caffeine. But when I'm working with patients, it's fairly individualized. So it's like, are you somebody that it has a big impact on? If so, maybe no caffeine is what you need to do. You need to find substitutes. Whereas if you're someone else, you might be able to have caffeine up until noon and be fine with your sleep, or up until 3. So there's a little bit of tailoring to that. Although, of course, ideally, I'm always, caffeine is ideal, but I know we live in a society that, and I do too. I had my Starbucks in here earlier, so I'm being a bit hypocritical, but I don't let my son, who's almost 13, he gets no caffeine that I know of yet.
You go. You're raising him for what you want down the road, so that's okay. You're allowed to do that till he becomes a teenager and fights back. It's coming. It's right there.
I know.
George, what is the appropriate age for a zPod?
This is such a good question, and we're still kind of figuring that out. But I think that it goes back to a lot of the principles that Dr. McCrae is trying to set, and that is, if it is too exciting for you, then that kind of defeats the purpose. And now, naturally, I think that a lot of kids, when they see this bed, exciting for them the first time anyhow, because it looks like it's a spaceship. And so the whole point of the bed, as far as I'm concerned, now we've talked a lot about the behavioral side of sleep, which I think is really important, but there is an environmental side of sleep hygiene, and that is that you're trying to create an environment in which you can relax. That's why it's important for you to keep your room clean. One really fascinating study would be where you have I think it was mice they were testing this on. They had mice where they cleaned the cage and mice where they didn't clean the cage. And the mice in which they cleaned the cage slept a lot better than those for whom they did not. And there was a lot of negative, consequences for that. And so the question I have is, for your child is, when your child gets in here, are you creating that type of an environment in which they to be able to kind of calm down? It's that's kind of the point. That's one of the things that I think is happening when you have the enclosure is you feel snug, not claustrophobic, but snug. And so we've had kids, I think our youngest that we worked is about 2 years old. We've worked with the bed and we've seen some good success with that. But we even have, like a 21-year-old adult female that we've worked with, and she'll sleep in there with her therapy dog, which is really adorable. But we've got some great pictures of that. We even have a dentist who just bought one for his office, and he uses it in his office to kind of chill out during the day. And so the underlying question, I think at all points, is how do I create for myself a place in which I can rest my mind? Because it goes back to those same principles that Dr. McCrae is talking about. So age appropriateness is a very hard question, because what one kid may find really wonderful, another kid may set off too many kind of alarms, like, oh my gosh, I can't believe I'm in here. We find, however, that even the most excitable kids, they come here as an act of rest. They don't come there to bounce on the bed, because they'll hit their head on the ceiling. And so it has kind of a natural tendency to affect the behavior, but it is an environmental solution alone. So we don't deal with, we don't deal with the behavioral side of the things that Dr. McCrae does, but we absolutely recommend that parents listen to her.
So it sounds like it's big enough to accommodate an adult if it would be a good system for an adult. So that's what I'm hearing you say.
It's 6'5" from end to end on the inside. I lie down in it and find it very chill, relaxing.
How much does it weigh? Does it cause any problem on a typical floor?
No, it's about 350 pounds, and it can bear 300 pounds per bed.
Okay.
We haven't seen any sort of floor problems, but it's certainly possible that could happen.
I'm going to suggest that anybody that's listening that wants to know more, and go check out the website for zPods. I think you can get a lot of your questions answered, and I'm sure that George is going to respond to any questions that comes through there to help you out and see if it's a good fit for your family. I want to ask about interrupted sleep. People that go to bed and they're sleeping fine, and then boom, they're awake at 2 o'clock in the morning and they can't get back to sleep. Any strategies for that, or any justification other than a busy brain as to why that happens?
That's part of chronic insomnia, where people sometimes have difficulty falling asleep, taking a long time to fall asleep at the beginning of the night, and maybe in combination with this, waking up during the night. And for some people, you wake up for just a few minutes and you fall right back asleep as you sort of cycle through the sleep stages. Other people, once they're up, and then that's part of their insomnia problem. So some of the techniques we already talked about can help with that, like the stimulus control, that when you're awake. And what we typically say is for about 15 minutes, or when you start to get that feeling, people who don't sleep well start to get that feeling like, oh, I'm not going to get back to sleep. They start to feel that little bit of that. They can sort of pinpoint that point. That's when you're going to get up and go into another room, do something non-stimulating, non-arousing, and then return to the bed when you're sleepy. And that's a technique that we use commonly. And we find that, I think sometimes people are like, I can't keep this up and keep doing this. Well, what we found when we work with people with those techniques is that pretty quickly, you do build up a little bit of sleep debt from doing those techniques initially, but then that sort of helps with your sleep drive, and you then start to sleep through the night better. And so it's usually in my work, within the first week or two, you find that you're starting to sleep through the night a little better. So it's not like we're saying get up and get out of bed and do that for the rest of your lives. Typically, the technique works quickly, and particularly when it's done in conjunction with some of the other techniques we've discussed.
Someone's asked about routines for bedtime, and I don't know if there's any like formulaic routine. It sounds like what you're saying is find calming strategies to prepare yourself to sleep. Are there other things beyond that you really want to get out here and share with our audience?
I'd like to add just one really quick thing. With my children, I have a storyboard with pictures on it of the things that we do as a routine, and so to create that type of a ritual out of it is really helpful, particularly with 2 of my 5 kids are autistic, but it really helps to have a visual on the routine.
That makes so much sense.
Yeah.
I think that, again, that routine, and you're giving them all the visual information about what to expect. This is what's going to happen for the next hour before we go to sleep.
That's exactly part of what we incorporate into our therapy. Is we typically will have the parent and the child work together to create a bedtime routine that works for them and their family. It might be anywhere from an hour to half an hour, depending upon the family. And then we have them create a poster where they sort of lay out visually what the routine is going to be. and have them practice it consistently.
With the work you're doing, are you only working with families in the Columbia area, or if there's a family that is experiencing a problem in St. Louis, would they be able to contact the sleep lab and get some support?
So currently, it's primarily people in the Columbia area for the project we're running, because people, if they were willing to drive, there are certain points, because it is a research study where they have to come and do certain assessments. If they were willing to do that, then there's no reason why they couldn't participate. But for many people, it's a barrier, the travel. So part of this study, and what I find is exciting, is that we are testing in-person versus remote version of the treatment. And so that's part of what we will be next steps. And then I'm also building a digital version, that we're starting with a version that we're calling Nightcap Spectrum for adults with autism. And then we're going to move in and test that and then create a digital version for families that's very similar to the in-person and telehealth version that we're testing now. So we know that's a problem, getting this treatment out there to people who don't live right around us.
That's really exciting. So there could be some opportunities down the road. Well, thank you. I think maybe I'll just beg you all to come back and update us on what's going on. You guys, go and get some good sleep tonight, because guess what? I'm directing this to you, moms and dads. If your kids aren't sleeping well, it's impacting your quality of life too. So this is worth taking the time to figure out. And if you need some help, call us at the ARC. Our family navigators would love to strategize with you about what to do. All right, everybody, have a great day. Thanks so much, Dr. McCrae and Mr. Bailey. It's been super fun.
Thank you.
It has. You're welcome. Thank you.
Bye, everybody.
Bye.